I'm happy to be here. I also want to acknowledge my two supervisors in-house, Professor Bart Krill, Professor Freddie Sengova. So I want to talk briefly about the issue of partnerships for UHC. And I want to start with a brief discussion, and I will take it from there. We define partnerships as a collaborative relationship between entities to work towards a shared objective through mutually agreed division of labor. Why do I want to start this? I want to highlight the point that partnerships are complex, because in this definition we are talking about entities, and here we are talking about actors who have mandates, who have interests, who have conflict of interest, and who have varied capacities to engage in partnerships. But we're also talking about the issue of working towards, which is a process issue. Processes are also complex, because when we talk of partnerships, key in there is building mutual trust, which is always a difficult thing to do. And then we are talking about a shared objective. And we've been discussing since yesterday, UHC, PHC, but I can tell you, having gone through so many countries in the WHO African region, the understanding is varied. Even at the senior level Minister of Health, people don't know what UHC is. They don't know the difference between PHC and UHC, and they're always asking us that, what is it that you exactly want us to do? So you can imagine that in a partnership, people are working towards something, they haven't really appreciated what it is and what it is not. Now, the mutually agreed division of labor, which is also a component in the definition, calls for dialogue. You know, when you divide labor, people look at it as a financing issue, that the more roles I have, the more funds that I do have. But every one of us must have something to do within a partnership. So it takes dialogue, and countries must have the capacity to engage in policy dialogues to get us to this agreed division of labor. So whether I look at it from, sorry, I'll just pick my glasses. So whether you look at it from a global perspective or a national perspective, it is the same. Partnerships will always be complex, because you're dealing with individuals, you're dealing with the processes, and you also have objectives which are always ill-defined. Now, there are several partnerships, and I want to come back to the presentation by Professor Yosua yesterday. Now, when we talk of UHC at the global level, I think we have the big umbrella partnership, which is UHC 2030. I don't know how many of us have engaged in that. And we also have several partnerships built around the building blocks of the health system. For example, the Health Data Collaborative, working on issues of data, M&E. We have the UHC partnership, which is looking at issues of governance and leadership, setting a strategic vision. We have Harmonization for Health in Africa, which is a technical support facility, again pulling together many actors to work with the countries in a more coordinated manner. Of course, we have the regional economic communities, the AU, and the list goes on and on. Now, again, at country level, we have similar arrangements, and the countries have tried to do several things to get partnerships going. Many have developed what we call a compact. Some have called it a memorandum of understanding. Others have called it a code of conduct. But what is in there is to really agree on the objective, to agree who is in, who is out, to agree what are the roles and responsibilities, and then people to sign up to these commitments. And also closely linked to that are the monitoring frameworks to monitor these partnership frameworks. I'll not talk so much about the public-private partnership frameworks, because Professor Kamarogo discussed that ably yesterday. But taking it to that front, of course, we can look at things like contracts, which are more in that line. And of course, the question is, what are the incentives and disincentives to working in partnerships? I think we can well appreciate the incentives. There's added value in working together, and somebody again referred us to a famous Chinese proverb yesterday, that if you want to go fast, you go alone, and if you want to go far, many is better. Of course, the incentive is to harness resources, to have bigger impact, but also to build that teamwork of we have something to achieve, and take pride in the successes, but also in the failures. But also there are issues that really confront us in trying to work with the partnerships, incentives notwithstanding. One big challenge we've had in getting this going is the other funding modalities. Because the warranty attribution. If we agree to share the successes and failures, then we lose the attribution. But we have Global Fund saying that I want to see what my money has done. And the same goes even for bilateral donors, but also other global health initiatives. The need for short-term results. In the partnerships, we talk of building mutual trust over time, which we cannot have in partnerships that require short-term results. And people say that, well, we are working in this arrangement, it is slowing us down, and we are supposed to report within 2 years. And then they justify putting in place other structures. And perhaps many of us who have worked with countries have seen this, for example, with the Gavi, where they came up with an immunization coordination group, even in countries that had child health coordination groups. And now, perhaps I want to talk briefly on how we can strengthen partnerships for the achievement of universal health coverage. And I want to raise a few points here. One is, how do we handle multiplicity in partnerships? But put up a slide that was crowded with all those partnerships. Professor Yuswa yesterday again talked about there's so many partnerships, the WHO AFRO, the regional economic communities, NEPAD, and so on. Now, my challenge with this is that we cannot figure out how to ensure complementarity in this multiplicity. Because when you look at these regional economic communities, when you look at the African Union, look at the WHO AFRO, we are all developing guidance documents for countries, and those guidance documents have commitments and targets, and we are all working with the same member states. But we don't have a platform that brings us together to make sure that we complement each other. And indeed, when you read these guidance documents, they are largely a duplication, sometimes contradictory, and also sometimes a source of confusion to exactly what it is that you want countries to do. And this, again, is mirrored at a country level. There's so many partnership arrangements, there's so many policy dialogue platforms. One time I was in a country, and I was attending the third meeting in the afternoon. It was being chaired by a commissioner who mentioned that it was his third meeting to chair that day, and all that changed was the agenda and the venue. Otherwise, the people are the same. We have a problem of multiplicity. People are just moving from meeting to meeting. We need room to implement. We need room to follow up on recommendations. How can we rationalize policy dialogue platforms? The issue of power within the partnerships, and power is not only a money issue. Even in knowledge can be a source of power. Even the mandate itself can be a source of power. There are some actors within partnership frameworks, in these partnership arrangements, who really feel left out. Yet they are key for the realization of UHC. How do we manage conflict of interest? This is something we do not talk about oftenly, and actually in majority of the countries within the WHO African region, there are no systematic processes to manage conflict of interest. Sometimes people who have this conflict of interest are the people to even sign on these proposals, even to sign on the contracts, and they are part of the partner group that is discussing whatever decisions you have to make. I've already touched on the issue of a common understanding, and I think if we talk of UHC, PHC, we really need to get this sorted. Every country we've been to supporting to develop roadmaps for UHC, this is what they're asking us. And I've had several versions where people say PHC is a vehicle to UHC. PHC is a subset of UHC. PHC is the same as UHC. So I think we need to fix this misunderstanding to help countries move on, but also to get partnerships, work together with clear roles and responsibilities in this agenda. Now, the other point I want to raise, we've learned this from our work on policy dialogue in Africa, the actors who are involved in this partnership. And I want to really highlight the varied capacities, which is a big problem. Some actors have no capacity to engage in policy discussions. When we talk of the community, even a simple question of who is the community is a big question. For example, in Liberia, and maybe many of you have read papers from Liberia where actually when they called the communities, churches came. But some people who were not part of that faith said we can't be represented by a church where we don't even subscribe. So who are the actors? How do we engage them? Do we have structures to engage them? And do they have the capacity to engage? So we are talking at this from two fronts, from the side of the actors themselves, but also the system to really have all actors engage in these partnerships. Now, I want to talk about the role of governments, because every time we work on compacts, we work on a memorandum of understanding, we are relying on governments to really spearhead the agenda, to set the strategic vision, to call everybody to order, but also to meet their own commitments. Now the challenge we have, governments are also defaulting. You know, when you look at the compacts, you look at the MOUs, in there are indicators, and also government has its own commitments, but they are always defaulting. So who is monitoring these compacts? What are the implications for defaulting? Who is demanding accountability from who if we are all failing? And I think we may talk of partnerships, we may talk of partnership frameworks, but this strong leadership from governments is very important. Government has to be accountable, but also has to demand accountability. You can't demand accountability when you are as guilty as the people who you are trying to call to account. Now, what are we doing as WHO? And I think I take this opportunity to say that the regional director has selected UHC as one of her flagship programs, and she's committed, she's personally involved, and she has put in place a plan, a roadmap for the region office, but also closely related to that, we are working with all countries to develop UHC roadmaps. And in there, we are really emphasizing the role of partnerships. For example, we go to countries and make sure that all partners are on the table to make sure that they contribute to this UHC vision, and also to commit to supporting some activities within these roadmaps. And I think we've been able to cover over 60% of the countries of the WHO African region. We also have a big program under the UHC partnership, which is really strengthening leadership and management. And much of our work is on building capacity for health policy dialogue. How can we dialogue towards a common objective? How can we sustain this? How can we make sure everybody is involved in the dialogue? The earlier days of the dialogue, much of this was housed within planning departments, but we've learned over time that we dialogue about everything. UHC is about many things. It's not only about health systems, and health systems should be looked at as a vehicle to take us to UHC. So we needed to really broaden dialogue, whether you are from program, we are from the community, we are building that capacity in terms of tools, in terms of training, but also mentorship of country teams. Thank you very much.